Ladies and gentlemen, please join me in welcoming Dr. Michelle Gibson and her talk, Any Problem, Any Age, Training Tomorrow's Family Doctors.
Here's a few questions to ponder. How do we train health professionals, and who makes those decisions? My name is Michelle Gibson. I'm the Assistant Dean Curriculum for the MD program at Queen's University, and I trained in family medicine at Queen's as well. I think we've all been there, where one day you're facing a health problem. Maybe it's that you woke up and your child has a fever and a rash. Maybe it's that you had dinner with your grandmother last night and she's repeating herself over and over and over and you know something isn't right. Or maybe it's you and that cough you've had for a long time just isn't going away and you know you should probably do something about it, but you're actually scared because you had a cancer scare a few years ago and you're a little bit worried about calling somebody because it might not just be a cough. So in that moment, who do you call? Well, I think most of us would want to call somebody that has knowledge and expertise that could help us in these problems. And in this case, you're looking for somebody who can help you with infant problems all the way up to seniors and everyone in between. You're looking for somebody who can help you sort out, is this an emergency? Is it something we need to deal with this week? Or is it something we can deal with later? Do we need to deal with it in the emergency department? Or is this in a clinic visit in a little bit? Ideally, I think most of us would also want to see somebody who sees us as a person and not the cough in room 5. And isn't it even better if that person actually knows us and has known us for a while and possibly even knows our family and understands why we are so concerned about what might seem like a very small problem? And that you don't have to share intimate secrets with somebody you just met. So who is this magical unicorn of a health provider? Who is this person that has the superpower to do all of this, who can take care of people from cradle to grave in all kinds of settings? Well, in Canada, this is your family doctor. And we trust them, and they are the backbone of our healthcare system. Unfortunately, we are in a major crisis in family medicine in Canada. Over 6 million Canadians do not have access to a family doctor. There's many, many reasons for this. It's all over the news all the time. But one factor is that fewer and fewer medical students are choosing to become family doctors. In fact, between 2015 and 2023, the number of students who were choosing to be family doctors dropped from 39% to 30%. So that makes a big difference. In order to understand why that might be contributing to the problem, we need to look at how we train doctors. So in Canada, if you want to be a doctor, first thing you do is you apply to medical school. We got lots of great medical schools across Canada. You do a degree program that's either 3 or 4 years long. Usually you start out primarily in the classroom, learning about sort of science stuff, different body parts, and then you work in different healthcare teams. In your final year, you have to decide what kind of doctor you want to be. And you do that by choosing which specialization you're going to apply to for after you finish your degree. So you may decide, I really want to be an obstetrician, or maybe you want to be a pediatrician or a pathologist, or, we hope, a family doctor. So this is where we're losing the students. Fewer and fewer of them are choosing to go into family medicine. At Queen's, we questioned, are we doing something in our medical program that might be discouraging students from going into family medicine? Or turn that around, could we do something better? Could we do something to encourage our students to pursue this awesome career? In 2022, we found out we were going to be expanding our class size. And there was a radical decision to do something very, very different. So the decision was to create a new campus 200 kilometers down the highway with our partners at Lakeridge Health that would focus exclusively on a program for students who knew they wanted to be family doctors. So when they're applying to medical school, they know that's what they want to do. This was novel in Canada at the time, and we had to figure out how we did it. At that time, as the Assistant Dean Curriculum, my homework, so to speak, was to work with an amazing group of people in a working group to try to figure out how the curriculum would look at this program. So I was gifted with this amazing group of family doctors and other educators to help build this from a completely blank slate, not being too focused on what's been done before, start afresh. The family doctors in this group were amazing. They were from all walks of life. Some of them were at the end of their careers, having held leadership positions internationally for years, and there were some that were brand new in practice who were helping us understand what it was like to be that brand new family doctor just out of residency. And we had everybody in between. We had people who worked in big cities, small towns, rural areas, clinics, emergency departments, people who delivered babies, people who took care of patients in long-term care. We had them all. There was no shortage of opinions. It was a great group, and the group came up with 3 guiding principles that we then used to build the curriculum at our new campus. These 3 principles were, first, the curriculum had to be structured to reflect the way patients interact with their family doctors. Second, that our students needed to have early and long-term exposure to many awesome family doctors practicing family medicine right from day one. And third, that the best people to teach medical students to be family doctors were family doctors. So if we start with how we organize the curriculum, again, it helps to look at how it's usually done. It's different all across Canada. Most of the time you start with, as I said, science-type stuff, and you then move through different body parts. So you might learn about the heart one week and people having chest pain. And then the next week you're learning about the lungs, and there's that person with the cough again. And that's great, and it works really well in a lot of settings. But that's not how people go and see their family doctor. People go and see their family doctor as a person who happens to have a problem, and not a body part saying, I have something wrong with me. So if you think about curriculum as being laying out cards in order, we shuffled the deck. So the first year of the curriculum is organized by the life cycle of humans, because that's how that works for family medicine. Our students start, after a brief introductory period, with a course where they learn about the health problems that young adults between the ages of 18 and 35 have. We can all pretty much rhyme those off. They might have pain from sports injuries. They may have trouble sleeping. They're having trouble at work or at school. Maybe they're struggling with substances. They probably have a cough. But also they're at the stage of life where they're looking at families. And so guess what? The next course is pregnancy and babies. And then you move through children and teens, different stages of adulthood right up until the end of life. And we have some specific teaching about how to approach patients with complex problems, because that's another thing family doctors do all the time and very well. And we talk about it early on. A curriculum, though, is not just the order of what you teach. It's how you teach. And so our curriculum there, instead of having an expert on lungs stand in front of the class and say, here's the 25 reasons people cough, is we start with cases based on patient stories that are already fully formed humans with real problems that are not just their cough. So instead of hearing about a 25-year-old that has a cough, you learn about a 25-year-old that's living in a multi-generational family where everybody's contributing to rent. And if he has a cough and he can't work, they might have to cut somewhere else. So it's never just a cough. And that's from day one. These cases are rich and developed and situated in the region where our students are studying. So they're interacting and they're connecting it with the community. They're learning in learning teams. So they are grappling with these cases together, working as a team, because that's how we practice. And they are guided by some pretty awesome teachers that I'll speak about in a minute. So the first year, they work through all of that in that format in their small groups. The second year, they return, and they do have a little bit more sort of body system organization, but they've had the grounding from first year. And then third and fourth year, they go off and join healthcare teams as junior healthcare members and learn a lot. And they do learn from lots of different kinds of doctors at that point too. So that's how we organize the curriculum based on the input of the group. The second key principle was that it was essential for our students to see family medicine in action right from the beginning. In the first month of medical school, they are matched with awesome family medicine mentors. They spend a half day a week with their mentor throughout the academic year, and they learn every day. They learn what a family doctor does. They see the patients come back. They see the patient's relatives. They see all the team. What's the role of the nurse? What's the role of the people that answer the phone? What's the role of the person who cleans the room? How does the family doctor navigate all that? And how do they help that person who has a cough when it's never just a cough? How do they approach that? In addition to the mentorship, which is in first, and then there's another mentorship process in second year, our students spend a whole lot of time in smaller communities working with family doctors and other health professionals to really see how healthcare works, where family doctors have a really significant role. They do 5 weeks in first year and 4 weeks in second year. So they have a lot of time immersed in healthcare settings where they're really seeing how healthcare works, again, to reinforce that. They take what they learn in these placements and bring it back to the classroom in their small groups, and they take what they learn in the classroom in their small groups and they bring it back to their clinical placements. The third point is that the best people to teach our students to become excellent family doctors are family doctors. They are the ones who can navigate all of this. We have family doctors who are the faculty working with the small groups, but they're also teaching students how to talk to patients and how to examine them. They're teaching students how to interpret statistics. They're teaching students how to handle public health. They're teaching students all these things. The majority of our teachers in first year and second year are family doctors. Don't worry, we do let some other doctors teach our students, but the key is it's the family doctors that help them navigate that stuff, that help them figure out what to do with that patient in front of them when it's a cough, but it's never just a cough. When we put out the call in Oshawa and the surrounding area for family doctors, so many people put up their hands. We had an onslaught of applications, and these family doctors are incredible. They are enthusiastic. They are engaged. They are embracing leadership roles. They are taking charge. They're helping us make things better. They're the ones who told us what to put in the cases to make them real and resonate within the community. They are giving us feedback all the time. This is working, this isn't working. How can we improve it? You can see how much ownership they have for the program and for the students, and it's just been inspiring to see. This leads me to where we are now. Our first group of 20 awesome students started in the fall of 2023, and another group of 20 students followed in the fall of 2024. They are not shy to share feedback, which is what we want. They're doing an amazing job learning this way. They also can see the value of all the placements that they do, and they are having a phenomenal time learning from so many different family doctors. They will be heading off on their clinical placements in the fall, and we look forward to them thriving there. But I think what's really important in all this is that if you put yourself 5, 6 years down the road, even longer, these students will be finished. They will be family doctors. And we hope that they will be loving it, and that they've had the support they need all the way through. And that when any of us at that point, 4 or 5 years down the road, have that moment where your child has a rash and a fever, or you're really worried about what's going on with your grandmother, or you're really, really worried that your cough isn't just a cough, you will feel completely confident calling them to help you through it. I know I will.